All right, fixing Zoom. Can you hear me? Also testing this mic for Zoom. Check, 1, 2. All right, we can turn that up a little bit. Yes. It's only one of these. Yeah. Or the last one only once. Yours been Zoom, but it's both once a month. Yes. So I mean, we've been experimenting with it, trying to see what people were encountering with it. I've got into the settings, tried to. I've been seeing like the waveform goes up here, like the green mic, so that we're good. Okay. That's why I just did that test right now to make sure. Okay. Okay. Hmm? Yeah, I'm doing that last check with the wireless mics and testing mic number 2. Okay. Okay. The right goes forward. I'll be right behind you if anything. Okay. 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 Hello, everyone. So we're in our third and final session for the day. I hope you've had great sessions up to now. I know the ones I've been in have just been so thought-provoking and really amazing. So I'm excited to hear from the groups we have here today. And then we'll have our presentations, and then we'll have some time at the end for questions. So feel free to keep your questions till the end. We'll have both groups come back up, and we'll have, I know we have some time, and I'm just going to hand things over to Penrose Jackson, who will introduce herself.
Thank you, Kristen. So my name is Penrose Jackson. Up until a few years ago, I was Director of Community Health Improvement at the UVM Medical Center. And since then, I've been working with other folks at the Vermont Public Health Institute, trying to launch the Institute, which has been a dream for a long time. And in 2021, we were given a unique opportunity. Let's see if this works. So we got a grant. And I'll go into some specifics about that, but we got a very large $4 million plus grant, CDC money through the Vermont Department of Health. We were subrecipient to work with communities and working toward health equity within their communities. We created an entity which was never registered with anybody, but the Vermont Community Health Improvement Project. And I'll talk about our hypothesis, what exactly did we do, how well did we do it, and is anyone better off? So the CDC money came through the Vermont Department of Health, as I mentioned, and it was to look at health disparities among populations at high risk and undeserved, including racial and ethnic minority populations and rural communities. We were subrecipient of a $4.1 million grant of a total of $28 million that was given to, allocated to Vermont Department of Health. We had a hypothesis, and I should note that several of us, if not all of us, have been involved many, many years with community organizing, community improvement groups, community engagement, and also had worked on the SIM grant Population Health Work Group, and really convinced about the concept of accountable communities for health being a vehicle that can bring people together and get work done. And so we came from that kind of belief. And part of that, we felt that communities know what they need. They have the genius to solve their own problems. They know what their challenges are. They know what their assets are. We don't need to come from away to tell them about themselves. They know themselves. I mentioned a minute ago the concept of accountable communities for health. It's imperfect, but it's a good model to move forward. We like the concept of collective impact, and you heard my intro. What did you do? How well did you do it? Is anyone better off? Are really the three concepts or precepts of collective impact. And leads to results-based accountability, which makes sense to most people. And we thought if we were correct in our hypothesis and we appropriately resource local collaboratives, and there are 12 health districts in Vermont, and we were talking about collaboratives in each of those 12 districts, 4, maybe 5 communities would continue to work collaboratively on health equity when the grant ended. And we were looking forward to 4, and we thought we'd be happy if that happened, and we needed to do our best work. I should also mention we had less than 2 years. So we weren't going to make tremendous change in 2 years. We could only seed change for the future. And I also should mention that someone at the CDC was very wise and said that none of the money could be used for evaluation, which is highly unusual with a CDC grant. The money was meant to work in the communities, which is where we put it to work. So I said as a minute ago that if at the end of the grant 4 community collaboratives intended to carry the work, we would say we succeeded. We came to the work with 2 principles, and really I should say 3. 3, the first being that the communities know themselves and they know what they can do to solve their own problems. But we were subject to a grant, so we said that each collaborative's work will address health inequities created or exacerbated by COVID-19. That was a requirement of the CDC. And we required that community partners with either lived or living experience will guide each collaborative's work. And we strongly encourage people to work in the communities to bring people with lived or living experience, the voices of those people, into the work at every possible stage and incorporate it in every way they possibly could. So we created a framework. The CDC money came to us, went to VDH, and came down to the Vermont Public Health Institute and our parent organization at that time, the Vermont Public Health Association. The money enabled us to hire 10 integrators that worked statewide. It was a half-time position in each of the 11 districts. Burlington was unable to anoint an existing or potential collaborative at the time of the grant. It was still the middle of the pandemic, and there are a lot of collaboratives in Chittenden County, and there was no obvious entity, so they declined to do that, but we did work with them, and I'll describe that later. So for the 11 districts, there were 10 integrators. 1 integrator covered 2 districts. And those 10 integrators each were employed by a backbone organization, a nonprofit in their area. And that's how the state's divided by the 12 health department districts. I thought it would be interesting, particularly for you all, to know who those backbone organizations were. And I've said many times that if we did this work 10 or 15 years ago, probably all of them would have been hospitals or perhaps United Ways. And we were fortunate that that wasn't true, and it showed that we had made some progress toward community engagement. There was 1 community action agency, 3 FQHCs, federally qualified health centers, 1 indigenous tribe, 1 nonprofit that served as a backbone, a bi-state public health council, and that was over in the Upper Valley, a regional planning commission down in Bennington, and unaffiliated collaboratives that really didn't have their status as a nonprofit, but we're working together. 2 of those used United Way as a backbone and 1 United Way. So very, very different than it would have been a few years ago. We applied the collective impact framework. There was action learning. The integrator staff really worked with each collaborative and also with us so that we can guide the work. And one thing I just can't stress enough, we did not tell people what to do. We gave them tools, techniques, a person, money, support, counseling, coaching, but we did not tell them what to do. So we provided technical assistance. We shared resources in every way we could think of. We had one-on-one coaching, so individual integrators and sometimes health district directors would seek some one-on-one coaching, and that was available to them at no additional cost. It was built into our work. We also had coaching on health equity. We knew that as three older white women, we probably lacked some credibility in working in health equity, and we engaged Health Resources in Action, which is the Massachusetts-based Public Health Institute with a long, long, long history of working in health equity work to work with us. And I mentioned them a minute ago. So one of the integrators at some point in this process said having the central organizers and facilitators to build on and maintain a healthy network of support is essential to ensuring that grassroots change makers are able to do what they do best, which is share information and resources. Sure. Okay, good. Is this better? And then remembering that most of the work, if not all the work, was really in the rural sections of Vermont. One of the backbone organizations, one of the nonprofits, said, in the rural landscape, even folks working on the same issues or dealing with the same obstacles may not know each other or how to connect. We can create bridges, work together to alleviate social isolation, improve access to health and wellness, and create more inclusive and thriving communities. So as I mentioned a bit ago, we had half-time integrators in each of the 11 districts who did all the admin and worked in a statewide collaborative. And they really, we supported them additionally in kind of peer learning and support. And as testament to the value of that, we enabled them to meet every Wednesday at noon and had a very loose agenda. And it was basically creating an environment where they could share information. And one of the coaches would be in those meetings if there got to be some gnarly issues. And as I mentioned, there were 10 integrators for 11 districts. And we had an average attendance at those weekly meetings of 8 people. And it was not the same 8 people, it was 8 people. And they weren't there if they couldn't be there. It was important to them. And each of the local collaboratives developed their own data-driven problem statement, and each local collaborative mounted and supported a community project funding process, which I will describe later. I mentioned the funding process. Each district got $168,000. And we just said, keep in mind, the work is to address health inequities of those most negatively impacted by the pandemic and in line with that health district's data-driven problem statement. And each of the district directors are well-schooled in how to work to create a data-driven problem statement. So they worked with their communities. Again, we didn't tell them how to do that. We said, look at the information that's in your community, look at the data, talk to your friends and colleagues, go out into the street and talk to people, and you tell us what you want to work on that's most relevant for your community. And they came up with 20 different areas of focus. We thought of health equity or health inequity in a very, very broad scope. And the projects funded social connection, resource access, health systems change, mental health and well-being, education, transportation. Some just wanted to do more training and workshops, storytelling, how do you tell the stories that are so important, leadership and advocacy, justice involved, outdoors and nature, and food access and insecurity. You can see it's a really, really wide range, and that came out of the communities who said, this is what we want to do. And in line with that, there were 18 separate focus populations, from low income to BIPOC, all inclusive of the entire community, LGBTQIA+, youth under 18, people experiencing homelessness, people living with a disability, health providers, older population, the people in the schools, international people, and indigenous populations. And so we said, how well did we do? And keep in mind that the CDC said you didn't have to do this. In fact, you can't spend any of your money to do it. So we kind of snuck it in. So we knew what we did from our office. We had newsletters, email, and 350 meetings with the district liaison. I didn't mention the smartest thing we did, and it wasn't our idea, somebody advised us to do this, was to hire a full-time person to just work with the integrators and the backbones. And she had 350 meetings, and she worked with them daily and helping them weave their way through so that we can meet the requirements of the grant while they were doing the work in community. We had 39 separate community projects totaling $1.9 million. They ranged from about $140,000 down to just a couple of thousand. Coaching supports, I mentioned those, 100 or more one-on-one coaching sessions, and also 100 group sessions. We reimburse expenses. We call them stipends, but it could be for all kinds of things. As long as a community building, is it pizza for the meeting? We can pay for that. Is it stipends to get people to the meeting? We can pay for that. Is it transportation? Yes, you can pay for that. Just get us a receipt and submit it, and we'll pay it. And the 11 local collaborative groups had, as I mentioned earlier, the 10 part-time integrators, and they spent collectively nearly $150,000 in those stipends. And it worked. In my 20 years living and working in the upper Northeast Kingdom, I've never seen a program do so much in so little time. It's given us the opportunity to more fully explore the needs of all the people in our region. We did ask them to do a bit of self-assessment. We asked them to do this at the beginning and at the end, and it was not comparable because a lot of people had changed. One of the things that we experienced and really celebrated, the people came in with the process in their community when they were ready to and when they felt they could have something to contribute. And then if time and fortune changed things and they weren't there anymore, that's fine. You came in, you had a presence, you made your contribution, but it made it very, very fluid in who was around the table. But we asked people to look back and saying, to what extent did you engage local residents? And you can see that it's starting to make progress, good progress, or fully in place. Asking questions to understand the systemic reasons on why problems are happening before searching for those solutions. Using action learning and rapid feedback to promote continuous improvement. Only 2 said not at all, and most were either starting to make progress or had good progress. And asking questions during planning and decision making to ensure you're advancing health equity. And we did this in a very gentle way, the whole process. These themes were in there, but we, again, never said this is how you do it. Feedback survey, we did have a kind of a closing meeting, and we asked, to date and at the core, this work has had a positive shift in my community. 88% agreed. And relationship building, I have formed relations within the Vermont equity community on a local level because of being part of this work, and 93% agreed. Is anyone better off? Sustainability, community projects that began during the grant, many continued beyond, and I know a couple of them were adopted by school districts and brought into the curriculum. Backbones and integrators, one of the things that surprised us, because it was only a 2-year grant, we said, probably the last 6 months we're going to start to lose integrators and backbones because they have a life to live. They know the grant is ending, and they were all there to the end. And they really stayed with it, and many have continued the work. And the backbone organizations did get some indirect support when they received the grants. We created a community improved community readiness toward talking about and addressing health inequity or health equity. Some have continued facilitation of the equity collaborative through coaches. Some have developed and implemented an equity commitment to future work with their community partners. Many improved skills, systems, relationships, and collaboration and access to funding. And the stipends to community partners prevent an avenue to increase participation. And as I mentioned probably too many times, we didn't evaluate it because we couldn't, but some of the soft things that we've learned, there's a story, and a woman who, I think it was a person, who had participated and had always been very timid and unwilling to really even speak up in a meeting through this process and being engaged through it. That person went to the legislature and testified on the behalf of affordable housing. And how many stories are there like that we simply never heard? As I mentioned earlier, if we were correct that local works and that people know their communities best and need tools and support in order to address the needs they know so well, maybe 4 or 5 would continue to work. 10 of the 12 are continuing in some fashion today. One received a Robert Wood Johnson grant, others a Bank of Boston grant, others have received local funding, and we're actually trying to get new funding for us to go out and really evaluate what worked and what were the best contributors and the most effective contributors to why the work succeeded, and how do we measure that success, both qualitative and quantitatively. What we have is better than anecdotal, but it certainly isn't going to support a research paper. We need to go deeper. What do we learn? The system is capable. We just have to give it resources, needs, and priority for action. And I just wanted to leave with a couple of thoughts, and I think we're going to have extra time at the end because I feel that's when you're going to learn what you really want to know. One of the community partners commented at the end that people, white people, who have the option to continue health equity work, but for the folks impacted by inequities, disparities, and outcomes of the work, it's not a choice to continue. This work must continue. And one of the district directors said, this work has been the one visible and tangible product to begin to incubate grassroots solutions to inequity that honors the ideas of those most burdened by unjust barriers to better health. So we'll end now, and we'll have questions at the end. Thank you.
Want to come on up? Great. Just looking for your slides. Nope, a blank presentation. There we go. This one, right? There you go. Just no, I have put it down here. But I have probably a little yeah, great. When you answer this one, actually, I think they're both for you, but they're Zoom, but just have one ready.
Good afternoon, everyone. Thanks for coming. My name is Corey Howarth. I'm a family nurse practitioner. I work at Dartmouth Health. I am also one of the co-medical directors for our mobile integrated health program. I'm the primary care director for that. Our emergency room director for the program was unfortunately not able to attend today, but that is Tom Trimbarco. And I'm here with the MIH team to kind of present some of the work that we're doing in MIH and some other work that I'm involved in with reverse integration primary care. And these two groups, the way that we kind of straddle the same care paradigm, but have started to integrate and overlap in a way that I don't think any of us anticipated. So before we begin, I'd actually like the team to come up and introduce themselves, because I feel like in the grand scheme of this, I'm actually a pretty minor player, and these are the people who are out there and actually doing the work every day.
I guess I'm walking up to the microphone.
I think the Zoom people.
Hi, I'm Amanda St. Ivany. I'm one of the community nurses with the Lebanon Fire Department.
I'm Jeremy Tebow, and I'm the community paramedic for the Lebanon Fire Department.
Rachel McMillan, community nurse with the Lebanon Fire Department.
Just a quick slide on some of what we're hoping to get across today. So I'm going to start with our reverse integration primary care clinic, and then I will have the team come up and talk about their roles in terms of the mobile integrated health program. About almost 2 years ago now, a physician colleague and myself applied and got some grant funding to take primary care out of our traditional office setting and bring it out into the community, right? And I think her and I had that, the common pie in the sky idea of like, if we could get a van, right? That would fix everything, right? A nice Sprinter van, right? You get a donor. This thing's going to be awesome. And yeah, after we look through the lit review, for rural communities, a van really isn't a viable option, right? The distances are just too great. So we had to kind of recalibrate what we were thinking, and we came up with the like backpack and a plan idea, which was utilizing what we do very well in primary care, which is we provide excellent care with a minimal set of tools, and then bringing that out to the community. We both had a passion for underserved populations, and in particular, the substance use population. So we were able to partner with a substance use treatment center who's affiliated with Dartmouth and get some space there. Right. And essentially, we were given an exam room, and we each committed 1 day a week to be there to see patients and provide primary care services, like on demand as needed primary care services. A lot of it initially was a lot of wound care, right? A lot of acute dental issues, right? Things that people have been living with on the street. And over time, we built these relationships that then allowed people to keep coming back to us. And then I could sneak in like my agenda, right? Which is health promotion. But the key was to get people to keep coming back, right? So kind of following the adage of like, I'm going to keep the door to my exam room open. I'm going to keep my mouth shut, right? I'm just going to listen to what people need, and I'm going to meet them there. So here's just a little bit of what I was talking about. This facility is located a mile away from our medical center, which probably for most people in this room is not a big issue, right? Just drive a mile up, get care there. For the population we're serving, this is a huge barrier, right? 1 mile means everything. It's gas money that people don't have. It's rides that people don't have. It's time that people don't have. And a lot of times people are making a decision to, they can come to one appointment, right? So they're going to come to the folks who are helping them with their substance use, or they're going to come to primary care, right? They're going to come to talk to the people who are managing their most pressing issue, which is not primary care. So by being there, they can just walk over and see one of the two of us. So that's just a brief overview of what I'm doing there. Now I'd like to kind of introduce, or have Jeremy introduce what he does as a mobile integrated health paramedic. And once we kind of get through this, I promise you I'll bring these two things together into some type of cohesiveness.
So the Lebanon Fire Department is your classic all hazards fire department. We cover about 4,000 calls a year, a little bit more. We're probably looking at 4,600 this year, with only 6 people on duty. So we sort of ventured into this realm and approached Dartmouth about a partnership, which we'll talk about in future slides, with the goal of reducing 911 calls. We're simply too busy. Every year there's about 400 calls that the Lebanon Fire Department simply doesn't have the capacity to handle. So that was our ultimate objective in beginning to have these conversations. But we found out that there's a whole lot of other things we can do through this partnership. This is a breakdown of the call volume. Like every municipal fire department in the country, the majority of what we do is EMS. We're slightly higher than average at 71%. Lots of times, I think the national average is about 65. Our program is broken up into 2 different parts, as you could probably already figure out from the group that we have here. We have community nursing, community paramedics. We're one of the few programs in the country that has nurses and paramedics both integrated into the same MIH program. You're back.
So the purpose of the MIH program really is that it's patient-driven, it's patient-centered for underserved populations, and it's a new way of getting care out in the rural communities to patients where they are, right? Which is they're spread out, And this gives us bandwidth that we don't have in the conventional brick and mortar clinic setting. It allows us to go, if they live in an encampment, if they live in a tent in the woods, if they just have an apartment that's too far away that they can afford to get a ride to the medical center for, we can get to them there. Do you want to talk a little bit about community paramedicine?
So we also did a little review when we started this program, and there were a few definitions. We kind of mixed like 3 or 4 different definitions of what community paramedicine was and made our own. This is what we came up with. Community nursing is a model that's been around for a little bit longer, with a little bit more backbone to it. When we started this program in 2021, which actually really started more like 2020, but we started delivering in 2021. Everyone sort of has an idea of what the community nurses do. A common question we get is, what's the difference between like visiting nurses and community nurses? And that, for the most part, comes down to funding and qualifications for services, where we can literally see anyone in the community.
So this is a slide a little bit more of what I was talking about earlier, right? Patients are often having to make this choice of, where do I get care and what care am I going to prioritize? Because I can get one place. So by taking primary care out to the SUD treatment centers, we've been able to meet people where they are. The MIH program can do the same, but we're a little bit more mobile than we are. I can't count the amount of times I have patients say, hey, I got here to see you, I don't have gas to get home, right? And this isn't like, oh, I hop on the bus and take the bus home, right? This is, I live 50 miles away. I live 20 miles away. These are huge barriers. Oh, I guess I'll walk. And so to think about those interactions, and then me telling someone, well, come back and see me tomorrow, right? Or, oh, I can see you back in 2 weeks. I have an opening in my other clinic. It just doesn't work for people, and they're going to forego that care. And for the most part, this population is a population of people who have been like run through the meat grinder of the healthcare system, right? And they've just kind of been spit out the other end. So there's a lot of distrust amongst people. And the worst thing that I can do as a provider is be like, hey, I'm new here. I really care about you. Trust me. I'm just going to keep showing up, right? It's like, how many times have they heard that? So they're just rolling their eyes when we first meet them. Both these programs, to have them be successful, there's been a lot of tincture of time, right? Of just constantly showing up and actually doing what we're saying we're going to do and building that trust. That's the only capital we have. We're both really, if I were to distill it down, like the reverse integration care that I'm a part of and mobile integrated health, we are providing primary care in 2 very different ways, and we're providing on-demand primary care, right? We're giving people the access that they need, usually for non-emergent care, although it's been great working with Jeremy because he's helped me out in a couple of emergent cases. So that, building that relationship has been really, really key. The other question that always comes up that I don't have the answer for, right, but it's the eternal philosophical question, and that is, to bill or not to bill, right? How do we keep these things afloat? Actually, the primary care program I'm in, we've chosen to bill everyone, because you can do all or nothing, right? You can't bill some people and not bill others. So in order to keep that group afloat, we've chosen to bill and have that revenue return to primary care so that we can offer triage nursing services and all the other asynchronous care services we offer our patients in our standard clinic. For the MIH group, we currently do not bill because it's just too hard with the current CPT code environment to bill. So I don't know if there's a right or wrong answer, but I feel like we got a pretty good litmus test here, separating the two groups out. So like I said, our goals are shared, right? Like these are all primary prevention, primary care goals. Just a nod out to our team, so our MIH team. And we're super lucky that we also have Dr. Kraft in the back room, who has been instrumental and extremely supportive. The other people who are not here today is Barbara Farnsworth, Hillary Schuler, and Captain Wheatley from the fire department, as well as Dr. Trombalco, who's not been able to be here. For the reverse integration primary care, you've got myself, my colleague, Dr. Shoemaker, who is, because it's Monday, doing her day at a reverse integration clinic, which is why she can't be here. And we've just had fantastic support from our medical director, Janice Valmasor, who's also in the back. And I just want to highlight, like, how awesome it is to work here and that we get the support of the people that we work with every day. And do you want to talk a little bit about kind of the training for a much?
Okay, so when we started this program, the community paramedic program existed, but it was in little tiny pockets around the country. So we didn't have to, we chose to, rather than have me, spend 2 years getting trained, we wanted to spend the money right now and get to work right now. So we purchased a CAN program put on by the Academy of Surgeons, and then through the medical direction team and other all the specialty clinics and places that we were going to interact with, we just partnered with them and did clinical time and didactic time, including places you wouldn't normally think about. I spent a day with the triage nurses. We spent a couple of days traveling around with a VNA nurse and a VNA physical therapist. We spent time in a bunch of different specialty clinics. This is just an example of a few of the ones that we spent a lot of time in, trying to get me trained up. I had a lot of experience in EMS, but not a lot of that transferred very clearly to primary care, right? Somebody's sick, I bring them to the hospital, and then I leave as quickly as possible. So that was a little bit of a change. This is actually way easier to see up there than it is on here, but still not that easy to see. This is a ground up program that we had built with very few other resources. So this is an example of a bunch of the smart phrases that we created inside the reporting software to be able to do the documentation, which was not a small feat, but thanks to a bunch of support, we managed to get this to be fully integrated into the hospital's PCR. And then the state requirements for reporting still fall into place, right? We are still an EMS agency that's operating this way after all. So in New Hampshire, we're required to complete what's now New Hampshire ESR. The equivalent in Vermont would be Siren. But both states have recognized that those are really EMS PCRs that don't necessarily fit the bill. So New Hampshire has just recently purchased the community health module from their vendor, which is a piece of beautiful software, which is something I never thought I'd say about ImageTrend. And I also have a short form, so I literally just fill out the minimum information that's required by the law and then do all the rest of my reporting in the hospital software. Just a blow up of the documentation, all the things you'd expect: standard time, coordination time, referrals, the reasons, how the visit went. Our initial visits for all three of us include a home safety evaluation and a social determinants of health evaluation. We've got the tools set up in the software to support us. I think that's really what's unique about it. And then communication. So when we have a problem or when we have a question, what do we do with it? Generally, we try to reach out to the referring provider. It's our first choice. The second choice would be the primary care provider if they're not the referring provider. And then we have our normal medical control tree. But beyond kind of the medical control you'd expect from EMS, we've also added the our two MIH medical directors, the normal, then the tele-ED as the kind of third tier of options for when we have a question for right now. And then lastly, we can just do online medical control with whoever the attending in the ED is that day. We have had really good success ending this, only getting down one or two tiers. Generally, any questions we have, someone is able to help us really quickly. I'm going to click through all these and just probably go too far, but yeah, see. So we accept referrals for the paramedic side of the program, primary care, emergency department. The geriatric emergency department has made a lot of referrals, bunch of different specialty clinics, inpatient teams, care management, and on the nurse side of the committee, they will accept referrals from literally anyone in the community. People can self-refer, they can refer their neighbors, and that has proved to be really beneficial. Far and away, our main referrers for both sides of the program still remain primary care providers, which just speaks to that integration. Reasons we get ED referrals. ED referrals are people that they generally, the ED generally refers people they know will not follow up. So we get rather than have them come back to the ED in 2 days, these are people that they are all but guaranteed aren't going to go follow up with their doctor, which is their normal discharge instructions. So when they have good reason to believe that that's not going to happen, they refer to us and we go out and do the follow-up. So there's a whole nother side, sorry. And reasons for primary care referral. You want to talk about this?
So very similar reasons why we refer from primary care, right? These are folks who we're worried about coming back to the clinic to see us for a variety of reasons, or just timeliness, or straddling that line between being able to come back and see us in 2 weeks, or is this going to tip over to the side where tomorrow they have to go to the emergency room? So it provides us a great opportunity then to get someone out in the interim. We're actually trying to build out a pediatric component, especially given the respiratory virus season that's going around. And we all know kids do really well until they don't, right? And so being able to have someone who can go out and listen to a kid's lungs to see how they look when they're calling triage, and the triage nurse is like, I don't know, it sounds really bad and it's a kid, they should go to the emergency room. If we could prevent them from going to the emergency room and give them a little bit of care at home, it would be huge.
Right, so creating an MIH program, it's a little bit easier in New Hampshire than it is in Vermont, but in New Hampshire, it's through what's referred to as a prerequisite protocol. So there's a set of protocols at the end of the EMS protocols in both states where you can do those things as long as you go through an additional process, prove your training, have a QA program, things like that. It does require both a primary care medical director and a EMS medical director, or the department's EMS medical director has to sign on. To do all those things. I think I hit most of that list. And then you can do that. In Vermont, it's a special project. So just like any other EMS special projects, that might be research. It could be an MIH program. It could be that, an agency wants to do surgical crikes. They all kind of fall under the same category of special project applications to EMS. I kind of talked quickly about intake visits. We identify the medical concern and the patient's goals, right? The reason we got referred is very often not why the patient wants to see us. So it helps to build trust if we can focus on their issues rather than just why we got sent there. We always include a med rec in the initial visit and then kind of as needed from there. Talked about doing social determinants, home safety assessment, physical exam, and then whatever interventions are ordered for those treatments or just patient education. And we do follow-ups and communicate. I'm just going to skip down a list for you. Follow-up visits, then they just start to get more and more focused. And sometimes we have to move back to other portions. We might need to be revisiting some portion of their social concerns on every visit. Or, I like today I went to a visit and gave a lady a shot of Omegli for her migraines, and I was there for like 3 minutes. So it's all relative based on patient needs. And outcomes.
So outcomes for the MIH program is really, we've tried to focus on reducing the readmission rate into the hospital. And then outcomes for reverse integration primary care, we've been trying to focus on, can we actually get people to do some preventative screening, right? Can we get some labs done? Can we test for HIV, Hep C, all of those things? And it sounds really easy, right? Again, we've got the medical center a mile up the road from where this clinic is. A mile up the road is really far for a lot of people. We actually have a little community hospital that's maybe a quarter mile up the road. Even that is really far for people to get to get labs. So I promised I would kind of tie these two things together, right? Because I have a foot in each canoe, and I feel like I have a vested interest in those canoes not moving further apart from one another. But what we've been able to do is actually have Jeremy come down to our co-location site and draw labs for people who really need them. Like, we had a woman who had been on lithium for 5 years and never had a lithium level drawn, right? And it sounds like such a simple thing. Oh, yeah, we can come down, draw that one lab. It was huge for that one patient and for all of the providers to feel like, okay, her level's safe, like we can continue with this treatment. I've been able to refer out to this program to actually all 3 individuals here, different patients. Mainly that actually I've seen at my reverse integration primary care clinic that I really, really need close follow-up on, right? But who can't come see me every week. And sure as heck can't come up to my other clinic. So the ability to have 3 people that I trust completely go in, meet my patients where they're at, and then be able to document in a medical record that I work in is huge. It's like real-time updates. It's, the care that they provide, for me, is just like reading an office note from a subspecialist. So I feel like I'm extremely well connected to what's going on. And I get a lot of great, like, hey, Corey, can I call you for 5 minutes and talk about this person? It's just fantastic, like bringing that care to people who really need it. I think it's probably the same up here in the UVM area as it is in the Hanover or Dartmouth area. We care for the most resource-rich people and the people with the least resources, all within, Lebanon city limits, Hanover city limits. The way that the MIH program is contracted with DH, Jeremy is bound by the city limits of Lebanon. We've been able to get creative by having people come into Lebanon, then within the city limits. But again, we're talking about people who have trouble getting to their appointments regularly. And if they could get to Lebanon regularly, they could come see me in my regular clinic. But we've also been able to expand out the nursing reach to some communities a little farther afield, which has just been key to being able to continue to provide that basic health care that everyone deserves. So it's just some basic slides from this kind of middle of the program, and the amount of combined visits that both nursing and the paramedicine program have seen. And Jeremy can probably speak to these slides a little bit better than I can. But patient satisfaction, I wanted to share a couple just slides with like the response that we've gotten from the people who have been referred. It's been just hugely successful. Do you want to talk a little bit about the numbers? Sure.
So, limited to just the city of Lebanon, our numbers remain pretty small. So, as we start to measure outcomes at 3 months, 6 months, we can sort of see that we might be moving the needle, but it's not in a way that's statistically significant. Where we have been able to show a change is not there. Where we have been able to show a change is in 911 calls. There is a little bit of anomaly that if you think about makes a lot of sense. When we get involved, 911 calls actually go up for a lot of people at first. Because lots of times we go to visit them weekly and we walk in and go, oh, again, all right, I need an ambulance. Or they're actually starting to think about their healthcare and realizing that they have a problem that they don't have to have. So we see a little bit of spike when we're first involved. It levels out through our involvement. It remains level for about 6 months, and then it starts to pick back up again for a lot of people. Some people, we fix their problem, and they get enrolled in regular primary care, and it's not a big deal. Other people kind of relapse back into it. And we'll often see those people for other visits as well. This one sort of shows, that's really hard to see there, but the blue box is 911 calls prior, orange is during, and gray is after. So that's at a 6 month, that is a 6 month evaluation of before, during, and after. And you can see we've got some outliers that call a lot. Improved staff experience. This is both referring staff and staff of the fire department that's answering these questions. And on every discharge, we send a survey to their care team and the referring provider. And this is the Lebanon Fire Department staff satisfaction survey. Even though they have to deal with us every day, they still sort of like us. And a resources page. So if you were to scan this QR code, it will bring you to our toolkit, on the other side, which as part of creating this program, our goal from the beginning was to document everything we were doing so that we could hand the model off to other people. A lot of it is kind of Dartmouth specific, and you might need to tweak it a little bit to apply to your health system. But if you're a New Hampshire community in the Dartmouth health system, then all you have to do is copy everything we did and you'll be good to go. Thanks very much for listening.
Thank you. That was great. Penrose, do you want to come up and then we can ask questions of all of you? Who has questions? Where do you want to start?
Hi, so my name's Sarah McKee. I'm one of the managers in our PHSO at the UVM Health Network. And we are starting to think about doing some of this work, and we actually did purchase a van to start doing some of this work. And one of the things we're trying to incorporate is potentially like closing care gaps, which it sounds like you are by getting some like labs and stuff drawn. As well as incorporating potentially annual wellness visits. Is that something you've thought about or are doing at all?
Yeah, the annual wellness visit is, I think everyone does it a little bit differently, right? I know that some systems actually have nurses do the AWV. At Dartmouth, at least in primary care, the providers do. So all the nurse practitioners, PAs, and physicians do them. But there really is no reason why it couldn't actually be done via telehealth and be done by any of the three people up here. It's just something we haven't kind of instituted quite yet. Does that answer your question?
I'm just going to ask a question online. So Kirk is asking, is the care you provide typically to patients who are unhoused? If not, how do the nursing services provided differ from home health care?
Well, I guess I'm holding the microphone. So we have partnered with some other folks in the city of Lebanon to do pop-up clinics for people who are unhoused, so they can come to a place that's a winter shelter in the winter, but does not have beds available in the summer. We have met with people who are unhoused at our Human Services office. We've met with people at the Listen, which is one of our nonprofit community-based organizations, and we are different from VNA because we don't need a physician's order. I'm going to keep it short and sweet. And funding. Yeah.
Right.
First, you guys are just awesome. I'm so happy to hear about all you're doing. But I have some nuts and bolts questions. So, how many patients do you see annually? And who's scheduling the appointments? Or they're not calling 911, right?
That's, apparently I needed it back. So we just kind of have some magic hoodoo voodoo to decide how we do our own scheduling. We have a shared calendar. The people call us. We talk to primary care people. We call the nurses. Sometimes we'll call people on the off week. So if you were my patient that I was visiting regularly, I might just schedule my next visit 2 weeks, 3 weeks, 4 weeks out, or I might say, I'm going to call you in a few weeks, check in, see how it's going. If we can see your medical record and I know something's kind of spiraling or cooking, I might see you 10 times in a week. It just really depends. There's no set limit to who we see. And I don't remember how many patients we've seen this year so far. I mean, I'm part-time, so 5 to 10 home visits in a week is a lot from me, also because people don't want to see me before 10 a.m. or after 3 p.m. So you got to try to slot those people in. Yeah.
Year to date for this year, we're at about 90 for nursing and 62 for paramedic.
My battery died, so I don't know if there are more questions online, but are there more in the room? Yeah, go ahead.
This is a question I was originally thinking about for Penrose, but I think it actually goes for both presentations. When you think about intervening at a community level, what makes, I know sometimes some places think that like a town of 1,000 people is the community. What makes sense as the level of intervention when you define community?
We didn't define it, and we, as I said, left it up to the communities. This is a perennial problem because it's a community. A community could be 3 people, and that could be a community, and they feel solidarity and all the things that make a community. Or it can be New York City calling itself the Big Apple and feeling pride in that. So we again didn't put any constraints on it. I think the organizing principle, if there was one, was health inequities either created or exacerbated by the pandemic, and the requirement they focus on that.
I would agree with that statement. I think, we also have not really looked to define the community. We've just said, hey, we're here, and these are some non-traditional places that you can access us. And we really do bare bones, basic, just care about your health, right? And we're trying to make it more accessible for you.
A good example of that access piece is that the first pop-up clinic that we did at the shelter, we had 2 people. The second one, we had 20. All of those people were unhoused. The third one, we only had about 10, but most of the people that came in cars. Like they drove there for the clinic. and we don't really know where they came from. We didn't ask, but there's definitely a shift.
Do you think that part of your success is that going into Dartmouth or going into these larger healthcare facilities, exceptionally overwhelming for a lot of people? So that by minimizing the size and the space, you're really allowing those persons, those fragile, acute persons, to have that care?
Definitely. We are also able to bring out technology. We have a hotspot, so we can bring it out to people's homes, so we can help navigating the healthcare system is a huge part of what we can do, especially for elderly folks and with the substance use populations. So much of that. You can't care about your health if you are concerned about your safety or the overwhelm or the getting through the phone tree. Like call and the like press one and they're just, nope, I'm out. So yes, definitely. I think that's a big part of it. Creating safe spaces to be able to navigate that, whether it's at the shelter or in people's homes.
Are you still the only service in the area? Are you seeing others branch out and pick up on your model and do the same thing?
Jeremy might be able to speak to that a little bit better than I can, but I wanted to touch upon just your first question there too. I think in terms of navigating the healthcare system, if we think about the people who've really been through the ringer with these larger systems, if I say, I want you to come see me, I am the nurse practitioner. I want you to see my colleague, she is the physician. There can be some resistance there just based upon past trauma. But if I say, hey, I work with these two really awesome nurses out in the community and they're through the Lebanon Fire Department, or I work with this really great guy, he's a paramedic. Like, that's such an atypical healthcare provider that a lot of people are like, oh yeah, that makes sense. Like, I'll see them. Right. So it also, just by being out of the box a little bit, presents us with a great opportunity to help with that navigation.
And I will just say quickly that there are several other communities in the Upper Valley and around New Hampshire and Vermont that have community nurses, but the model is very different. They're most of them independent contractors. They're not part of a mobile integrated healthcare team. Our model is, I think, superior to that just because we have other resources and they all do great work, but everybody does it differently.
CommunityNurseConnection.com if you want to explore that. There are other MIH programs throughout New Hampshire. Don't know where Vermont stands. New Hampshire has about 9 programs in various degrees of running at the moment. Most of them are just getting started. A lot of them got the SAMHSA funding at the end of COVID. The hardest part for MIH programs is funding, right? As Corey said during the lecture portion, the billing codes just don't support EMS not transporting, which is hopefully something that's going to change in the future. But funding is the big piece. There are lots of programs start up and then they expend their grant money and go away. One thing that we're doing that we're hoping will lead to a billing avenue is what we're calling enhanced telehealth. So I can, or any of us can go out and be the hands for the provider that's on the other end of the computer screen. So that's allowed us to expand into some areas that normally wouldn't be appropriate for telehealth, like wounds. I do telehealth visits with the comprehensive wound clinic quite a bit.
All right, this will be our last question.
I know you do some follow-up on referrals from the ED or primary, but when you have the pop-ups, how do you socialize it? How do you communicate to people?
Other people do it for us. There's a whole committee of people out of population health and the community-based organizations. They all organize and advertise that. Really, we just kind of show up to provide services to that. So we're just stepping into that role. So they all work very hard to promote it. And when we see people, when Jeremy sees people frequently for wound care, xylazine wounds, we'll say, just spread the word, tell your friends to come. So it's word of mouth as well. But in that instance, we're very lucky that there are a lot of people who work really hard that aren't us to get the word out about that clinic.
Okay. All right. Well, thank you so much. That was a really wonderful discussion. And And we just have one more session. It's just a quick wrap up, but I think don't miss it because I know they've put some time into thinking about how to bring this all together and seal in all this listening and learning we've done today. So if you head back down to the main conference room. Great.
Great job, guys.
Mm-hmm.
Very well.
First people, but online people, thank you. That was great. Thanks for all your work. Thank you. But yeah, no, well, what's up? That's great.
Awesome.
We're not thing. I'm computer dying, so you are going to work with that actually. Yeah, I'm so tired of these.